Well, hello there, everyone. Thank you so much for joining us today. I wanted to introduce you to Dr. Anctil. He is our foot and ankle surgeon here at Tucson Orthopedic Institute, and he works closely with the nurses and doctors up on the fourth floor when the patients are admitted. So, Dr. Anctil, thank you for joining us today.
My pleasure. Thanks for the invitation.
Yeah. We just wanted to touch base with you and just kind of tell us a little bit about what you do and what kind of surgeries you're practicing right now.
I will. My pleasure. So, good afternoon. So, Rebecca, the patient that are admitted at TMC are mainly in three groups: patient that have ankle fractures, patient that have an ankle replacement, or patient that have hindfoot fusions. So just to tell you a bit more about each, I have a model here of an ankle, and you can see the red lines, and each red lines represent a fracture. So this is the ankle. You have the fibula here, you have the tibia and the talus. So if you have a fracture of that bone here, it's a fracture of the lateral malleolus. Right. Now, the other type of fracture you can have is the medial malleolus here. If you have a combination of both fractures, that's called a bimalleolar ankle fracture. If you have a fracture of the back posterior aspect of the tibia, that's called a posterior malleolus fracture. And now if you have fracture of the three, it's a trimalleolar ankle fracture. Now, anytime you fracture your ankle, bones can displace, and if there's a significant displacement, then you can end up with a subluxation or a dislocation. A subluxation means that the ankle is no longer perfectly aligned, so it's displaced a little bit like that. If it's a dislocation, that means the ankle is completely out of joint, so it would be like this, okay? So those patients are frequently admitted through the ER, although many of those patients are done as outpatient as well. Okay? Now, the second type of procedures that are admitted at TMC are ankle replacements. So an ankle replacement is done to treat arthritis of the ankle. So the arthritis would be here. So what we do, in the same way as they do it for total knee replacement, we basically remove the joint that is arthritic, that is worn out, and replace it by metal parts. So on that ankle here, what we would do, we would shave off the distal end of the tibia here and replace it with a little implant like this that is shaped like a plate. So it goes on the other way here like that. So it would go in like this. Then for the talus here, we do multiple cuts so that we can insert what I call a little cap implant, so it fits in like a cap over the talus. So once that is done, then we sandwich in between a little plastic spacer that allows the movement. So this is the Scandinavian total ankle replacement, or STAR. And that's the only implant in America that is sold that has three pieces. Okay. So we call it a three pieces or three-part replacement that allows gliding in that way. So motion up and down of the ankle, and also a little bit of rotation. Okay? Very good. So that's for the ankle replacement. Now, the third type of surgeries that are admitted at TMC are the fusions or arthrodesis. So if we, to treat ankle arthritis or other joint arthritis, we can also do a fusion as opposed to an ankle replacement, and that's decided in the office with a discussion with your surgeon. So if we fuse the ankle, we basically apply screws or plate and screws on the front of the ankle here to fuse the talus to the tibia. Now, there's other joints that we frequently fuse, and it's called a triple arthrodesis, and those are also admitted. So in that case, we will fuse three joints: the subtalar joint here, the calcaneocuboid joint, and the talonavicular joint with screws. Okay. So those are, Rebecca, the main surgeries that are admitted at TMC, although some of them are also done as outpatients.
Okay, thank you so much for sharing that. So for those patients who are admitted, because there are a lot of outpatient procedures, our nurses aren't as familiar with seeing ankle patients up on the floor. So a lot of them have questions as to what to do with that dressing. They come up with this big bulky dressing, and we have orders to reinforce that dressing. Is there anything else that you'd like us to do with that dressing?
So most of the dressings of those patients will stay on during the duration of their stay.
Okay.
They usually come in the office after a week, and that's when we change a dressing. And as you said, all that is required from the nursing is to do reinforcement if it bleeds through the dressing. Now, there's some patient that will need dressing changes. Those are mostly the patient that are admitted for diabetic wounds or infection. So then we change the dressing daily.
Okay.
Okay.
And there would be specific orders in the
There
chart
would
for
be
how to do that.
specific orders. Otherwise, it's simply reinforcement.
Awesome. So we do have that reinforced dressing, but occasionally patients will complain that that dressing feels too tight or uncomfortable. What should we do in that case?
So at that point, what you have to do is to elevate the limb, put it on pillows, and then bring in some ice to help decrease the edema of the limb. And if that does not suffice, most splints are made so that you have plaster on each side. So what you can simply do is first you use a scissor and cut in the front of the ACE wrap, and then you can grab the splints on each side and you just spread it apart.
Okay.
Okay, and that should be enough to alleviate that sensation. If it's not enough and the pain is still significant, then you let us know. You just give us a call.
Okay. Awesome. And so the nurses should feel comfortable doing that readjustment procedure.
Totally. That's not something that will damage anything.
Okay.
It's just for the comfort of the patient.
Perfect. So you mentioned elevation to help with swelling. We know that a lot of the times your orders will say make sure that you elevate that limb that the ankle was operated on. Are there any other helpful things that elevation does?
Well, elevation is mainly to help the venous circulation. Anytime you have a trauma or a surgery on an extremity, it disturbs the circulation going back to the heart. So we want to elevate usually above the heart. If you're laying down, then your ankle should be above your heart so that it favors drainage towards the heart. So that's the main reason. Also, it will be less painful to elevate. And also, if you have less swelling, it will help the wound healing. So those are the reasons why we request elevation.
Perfect. And so pain management is also an issue, especially when those patients are admitted, just making sure that their pain is managed. So elevation helps with that. And then what other methods have you found helpful to help manage the pain?
So most patients will come to the floor with a nerve block. And that's a popliteal block. That's where they numb the main nerve that goes to the foot in the back of the knee, right? And those blocks work hopefully for 12 to 24 hours and sometimes longer. So most of you guys know already that if they come on the floor with a numb foot and unable to move their toes, it's normal because they had the block. So that's the main way to help the pain while the patient is admitted. Then when the pain starts, then I'd like you guys to put the patient on Tylenol regularly if there's no contraindication. Many times I want you to avoid the NSAIDs because that can slow down bone healing in the case of a fracture or a fusion. And then, of course, you'll have some opioids if necessary, if that doesn't work. And then you can always, as we talked previously, just stretch the splint and make the patient more comfortable.
Awesome. So when that patient is ready to go home, what kind of things would you like us as nurses to communicate to them as far as their dressing or hygiene and mobility, those kinds of things?
So most patients, that are not going to be allowed to bear weight on that extremity for 6 to 8 weeks. So they should know already that they need to prepare for that. And how do they prepare? They acquire a knee scooter. They can acquire crutches, although most of the time crutches are provided at the time of surgery. And they should also, if they see the need, get a walker. And I recommend that they practice at home before their surgery so that they know what they're going to get into, and they modify already their environment to make it easier. So once they're in the hospital, then the physical therapist will work with them to improve their mobility, to be able to stay off the limb for 6 to 8 weeks. If it's not possible for them to go home safely, then we'll recommend that they go to a nursing home or a rehab facility. Now for the dressing, they don't need to change it. And if they want to shower, they can, but they need to protect their dressing, the splint. And they can either acquire a cast cover, it's called, something that stretches and cover the cast or the splint. Or more simply, they can use a garbage bag and tape it around the thigh, and then they put another layer of garbage bag above for double protection. And then they can shower, and they should get a stool for the shower so that they can easily sit to shower. And otherwise, for pain at home, they're going to be provided with some opioids for a short period of time, and they can always take the Tylenol. And in some patients will need also anticoagulation for prevention of blood clot. And it's either going to be aspirin twice a day, or something more aggressive like Xarelto or heparin.
If they were prescribed those blood thinners, how long should they expect to take those for?
Usually, we recommend that they take the blood thinners until they're able or allowed to bear weight.
Okay.
Because there's a higher risk of blood clots when you're non-weight bearing and also immobilized in a cast. So it's usually 6 to 8 weeks.
And then circling back to the showering aspect of it, it sounded like the main concern was keeping that dressing from getting wet, to cover it up and make sure that there's no moisture that gets inside of it.
That's correct.
Okay.
And should it get wet at home or at the hospital, please call the office. We'll be able to fit you right in the same day to change that. Even if I'm not available, our cast tech are instructed to help you and change that splint.
Okay, perfect. And then kind of the last questions that a lot of patients give us on discharges, when am I going to be back to normal? I'm sure that when it's not an emergent procedure, like you talk about that in your pre-surgery visits, but for those patients who kind of come in emergently.
So there's, to be normal, that takes a long time. So I tell all my patients that it takes 6 months to a year to fully recover. That includes the pain, of course, but also the swelling and the discoloration. Your foot, you don't have surgery and your foot can be swollen, right? So imagine if you have surgery, then that foot can be swollen for a long time, more than before, and then discolored. So that's totally normal if it turns bluish when you put it down. So don't be worried about that. Then there's the shorter term recovery. That means when can I walk on it? And again, it's about 6 to 8 weeks, but it's determined based on the surgery you had. So that's usually the main guidelines that I give about that.
Awesome. I don't have any other questions for you. Is there anything else that you'd like to add as we wrap up this discussion here?
No, I have nothing else. I think we gave a lot of information. Hopefully will help the nurses on the floor and also the patients.
Well, thank you so much, Dr. Anctil. We really appreciate your time today.
Thank you. Thank you for watching.
Thank you.